Some of their resources are going to be found in that handout section, again, to the right hand of your screen. So please take a look and, of course, get in touch if that is something that would be appropriate for you or a loved one at this time. At this time, I would like to formally welcome everyone to Finding Relief: Advances in Foot and Ankle Pain. We have such a wonderful event for you today with two great specialists, and I'm going to begin with introducing our first speaker, Dr. Stella Chienda. Dr. Chienda graduated from the University of Alabama at Birmingham with a bachelor's degree in biology. She subsequently went on to the Ohio College of Podiatric Medicine and obtained her degree there. Following this, she completed her surgical residency program at the Cleveland Clinic and Kaiser Permanente, and she has been hopefully happily working at the Cleveland Clinic since 2010. She enjoys treating bone and muscle-related problems of the foot. Since she's begun working part-time, she has stopped performing elective surgery, but does continue to perform emergency surgeries when on call in the hospital. She's currently seeing patients at main campus, Strongsville, and our Willoughby Hills location. And in her spare time, which I feel like maybe she doesn't have too much spare time, she does enjoy traveling with her husband and two children. Dr. Chienda, thank you so much for being here with us, and we're going to let you take it away.
Well, thank you so much for the opportunity to be here. Without further ado, we'll go ahead and get started. So I was tasked with talking about some common foot conditions, and we're going to cover some things that you can expect to hear me talk about today. I'm going to cover what is podiatry, when to see a podiatrist, and some of the common foot conditions that are seen by podiatrists, including heel pain, bunions, arthritis, and the diabetic foot. And hopefully we can get to all of that. Dr. Berkowitz is also going to talk about arthritis, so I might just skip over that so that we're not both talking about the same thing. So what is podiatry as a specialty? As far as education is concerned, a person would typically go for undergrad. After that, they go to podiatry medical school. And following that, residency is typically either 3 years or 4 years, depending on the amount of surgery that one wants to do when specializing. If one wants additional training for more complex foot and ankle surgery or complex foot deformities, one can pursue a fellowship after the residency program. So when should one see the podiatrist? Really, you can see the podiatrist for any condition that pertains to the foot and ankle, bone and muscle conditions, skin conditions, nerve conditions. And as far as the bone and muscle conditions are concerned, really the whole gamut of problems, from tendinitis, growths, foot and ankle injuries, broken bones, also known as fractures. Some patients ask me, do I have a fracture or do I have a broken bone? Well, it's one and the same. We see ankle sprains, any type of bone pain, arthritis, heel pain, bunions, and as you can see, I could go through the whole list here: hammer toes, flat feet, joint pain, etc. So anything really that involves the bone and the muscles and the tendons in the foot and the ankle, we will gladly see. We also see skin conditions of the foot and ankle. These specifically when we're talking about foot and ankle wounds, these wounds can be from poorly controlled diabetes. These wounds can also be from chronic leg swelling. Sometimes when people have swelling for a long time, they can end up with wounds, as is exemplified here. And we see patients with that problem. Sometimes poor circulation can also lead to wounds, and we can see patients for those as well. As far as skin conditions are concerned, we also see some light skin conditions, such as athlete's foot, as is depicted on the right. We see patients for warts, and we also see patients for growths. This one is a tumor that can occur in the bottom of the foot. We also see people for tumors that occur on the top of the foot. Now, I will say this, depending on the extent of the problem, we will sometimes end up referring these patients out. For example, if they have a growth that we work up and find it ends up being cancerous, then we'll probably end up referring it to the orthopedic oncologist to handle. If, for example, we try to treat the warts and we're not making progress, we would subsequently refer these patients to the dermatologist. And if the patient has refractory or stubborn athlete's foot that we just can't seem to treat, they might not have athlete's foot. They might have dermatitis or some form of eczema that we're not sure about. And in such cases, we would refer these patients to the dermatologist. So as far as some nerve conditions are concerned, we will see patients with neuromas. And neuroma is depicted here on the right. It's essentially an enlargement of one of the nerves between the bones in the foot. And this can lead to numbness and tingling and burning of the specific toes that the nerve supplies. I'm sure many of you have heard about carpal tunnel. A similar condition can occur in the foot, and it's called tarsal tunnel. And so we will see patients who have tarsal tunnel. These patients will typically present with some numbness and some tingling and some burning, particularly on the bottom of the foot. We will also see patients with bursitis. Pretty close to these nerves that are illustrated here are some fluid-filled sacs or bursa. Sometimes these can get inflamed, and when they impinge on the nerve, a patient can have symptoms similar to a neuroma. So certainly the podiatrist would be able to take care of that. I will say that with regards to any kind of numbness, tingling, or burning that's occurring on a more global level, as far as the foot, ankle, and leg is concerned, that's when the treatment by the podiatrist becomes limited. So we recognize and understand that numbness, tingling, and burning in the feet can occur from roughly around 25 reasons. And certainly the podiatrist would not be the specialist to try and parse that out and figure out what the etiology of that is. So this is when we would typically have the patient see the neurologist. So I would strongly encourage you, if you have any kind of numbness, tingling, or burning in the feet on a global level, not just limited to one toe or two toes at the bottom, if it's involving the entire foot and the ankle and the leg, the podiatrist would not be the person to see. You would likely need to see the neurologist for that, or the back specialist, to make sure that your symptoms are not related to your back. Again, like I mentioned, with regards to the skin conditions, we do treat some conditions, but again, if it's something that I always use the example, if it's not something that you would see the hand doctor for, a rash on your hand or a growth on your hand, if it's something that you would think about seeing the dermatologist if it was on your hand, the same applies. If there's some kind of rash or skin condition on your foot, you're probably better off seeing the dermatologist than seeing the podiatrist if you want definitive and full treatment as far as the complete workup is concerned. Some misconceptions about podiatry. It used to be back in the day, I think just even before I started school, if you needed your nails trimmed, you could just make an appointment to see the podiatrist and your insurance plan will take care of it. Unfortunately, with the changes in healthcare, things have changed, and routine trimming of toenails is no longer a covered service by any insurance plan, really. Patients have to meet certain criteria. For example, they have to have poor circulation, they have to have had a prior amputation, they have to have pain. And so if they don't meet these specific criteria, the insurance companies won't pay for it. And so you end up having to pay out of pocket. And this includes diabetes. Simply having diabetes, unfortunately, does not warrant coverage of the service. As far as calluses are concerned, having diabetes will get you covered for callus trimming and callus care, because the insurance companies recognize that those calluses do increase the risk of a wound developing. And so having diabetes will allow for management of calluses. Management and trimming of calluses will also be covered if your circulation is poor or if you've had an amputation, because you will automatically qualify for that service. But beyond those specified criteria, unfortunately, this is something that patients now have to pay out of pocket for if they want to have their calluses covered. So moving on to some of the more common foot conditions, specifically, like I said, I'm going to cover heel pain, bunions and the diabetic foot, and then I'll let Dr. Berkowitz cover the arthritis portion. And so you'll see me skipping over some of those slides. So I guess I will go ahead and skip through all these arthritis slides, and Dr. Berkowitz will talk about that in detail. All right, so we'll talk about heel pain. I chose to talk about heel pain because I probably, as you were told, I work part-time. And so in the 3 days that I work, I probably see about 15 patients a week who come in with this problem. So I figured I would talk about it because it's pretty common. And so the heel pain that I'm specifically talking about today is plantar fasciitis. Of course, you can have heel pain in other locations, but I'm going to talk about the most common that I see. And we're talking about pain on the bottom inside aspect of the heel. This heel pain usually results in about 1 million visits to the doctor every year, seems to peak between the ages of 45 and 64. And it seems to be more common in women, those with flat feet, those with high arches, those who stand for prolonged periods of time at work, and those who have a tight Achilles tendon. So just briefly covering why it is the bottom of the foot hurts without boring you with too much anatomy. There is a large ligament on the bottom of the foot, as is illustrated here. It's called the plantar fascia. So it starts in the heel and it inserts all the way in the toes. And it helps to maintain stability as far as the foot is concerned. Unfortunately, when people have a tight heel cord or secondary to repetitive strain and the issues that I talked about in the previous slide, one can end up with microscopic tearing of the fascia off the bone. And as the fascia tears off the bone, it leads to an inflammatory response. And it's this inflammatory response that leads to patients having the pain on the bottom of the heel. So what kind of symptoms do patients with plantar fasciitis experience? Most people will talk about pain after periods of rest, especially after they get out of bed in the morning. They have to wobble a little bit. And then finally, things seem to improve once they get a few steps going. They tend to also talk about the fact that the longer they're on your foot, the pain seems to get worse. So how do we diagnose plantar fasciitis? Well, plantar fasciitis is really mostly diagnosed on exam. And patients often ask me, well, how do you know it's plantar fasciitis? And I tell them, well, I guess that's part of the education. You get to learn where certain diagnoses will cause symptoms. So typically patients will have pain right here on the inside bottom of the heel, just where the heel meets the arch. Sometimes the pain can extend into the arch as well, but mostly it's going to be here. If people have pain on the bottom, that speaks to something else. So it has to be on the inside bottom of the heel. As far as other measures that we can use to diagnose fasciitis, we certainly order x-rays, not because we're looking for a bone spur. Patients often tell me or ask me, is my bone spur big? How big is my bone spur? Is it small? Do I have one? Do I not? The truth of the matter is that bone spur doesn't mean anything, at least as far as the bottom of the foot is concerned. There are other places where the spur is relevant, but on the bottom of the foot, there are many people who have spurs who don't have pain. There are many people who don't have spurs who have pain. It's simply not a bone issue. It's because this ligament has microscopically torn off the bone, secondary to various factors, and the tearing is leading to the inflammatory response, which leads to the pain that the patient is having. So when we order x-rays, we're simply trying to see if a patient might have a stress fracture of the heel, and we're also trying to see the overall anatomy and alignment of a patient's bones, because that can also clue us into the factors that might be precipitating the patient's symptoms. People often ask me, is it necessary to get an MRI or an ultrasound of the foot? Every once in a while, we will do that. We will order an MRI in very stubborn cases of plantar fasciitis. Most people get better without surgery. But should a patient not be making progress after we've tried the typical gamut of treatment options, we'll certainly order an MRI to see if there's something else that we might be missing that might be contributing to their symptoms. We can also order an ultrasound, and an ultrasound, I usually order an ultrasound when a patient relates some acute injury to the heel, which makes me suspect that they might have a partial or complete tear of the fascia. And usually the ultrasound will help us know if the fascia is partially, completely torn. And in that case, the treatment would be completely different from if it's just the microscopic tears of the fascia. As far as treatment for the heel, 85 to 95% of patients, like I mentioned earlier, get better without surgery. Now, the recovery course can take sometimes up to 3 months. So I tell patients this is a little bit of a marathon, and patience is the name of the game. And I'll often tell people as well that if you have a bum shoulder, you normally just put in an arm strap, and you're told not to move your arm. When you have heel pain and you typically go see the podiatrist, they'll let you walk, they'll let you go about your activities of daily living, unless, of course, the patient pain is so severe, maybe you put in a cast with crutches, but that very rarely happens, and I've never really had to do that before. So because we're allowing you to go about your activities of daily living, it will take a little bit of time to get better. I mean, if you sat on the couch with a cast and didn't move at all for 3 weeks, it will go away. But that's not practical, and that's not life. So it does take a little while to get better, but the key is to make sure that one implements the treatment measures that I'm going to cover up here. So it's important to rest. If you like to run, if you like to walk for exercise, we can't expect that those activities will continue. So we need to modify activity levels. I encourage patients to stop walking for exercise, to stop running. However, I allow patients to swim, row, or bike. Anti-inflammatories are always a good option. Oral steroids help to decrease the inflammatory response. Icing is also a good thing to do. Please, no heat when it comes to fasciitis. I know it feels good when applying heat, but certainly that makes symptoms worse. So always good to ice rather than applying heat. Now, stretching is absolutely paramount. Part of the reason people have heel pain is because the Achilles is too tight. And for as long as we don't stretch the Achilles tendon, your symptoms will certainly not improve. So we typically encourage patients to stretch about 5 to 8 times a day. And this will allow the Achilles tendon to become more supple, which decreases stress on the fascia and ultimately allows it to get better. Certainly no barefoot walking. That just further stretches the fascia, which we don't want. Other treatment options are arch supports. These are also paramount. We cannot expect that you'll get better if you don't get a good pair of arch supports or insoles. This is not where you get a cheap pair of Dr. Scholl's insoles that offer no support. We need something substantive that will help to support and maintain the architecture of your arch while you're walking. And this will help take tension away from the fascia. Physical therapy is another recommended treatment option. We often recommend night splints, which will maintain stretching of the Achilles tendon while you sleep. Certainly, patients can get steroid injections, but honestly, I rarely give these, maybe about 4 or 5 a year. People get better without them. And so in the stubborn cases or when patients insist on getting injections, I will give the injections. But most of the time, if people follow the protocol that I just previously outlined, people will get better without surgery. There's also some other, you can do extracorporeal shockwave therapy. This used to be covered by insurance, but it no longer is. And again, that's just something that we also offer patients that have pretty stubborn cases that are not getting better. So I can't stress this enough. When you're treating plantar fasciitis, it's important to recognize that you've got to do all the things in concert. It's not just enough to wear arch supports. It's not just enough to stretch. It's not just enough to ice. Everything has to be done in concert in order for a person to get better. And if everything is done in concert, patients will typically get better. 50% in about 6 weeks, and mostly about 90 to 95% by the 3-month mark. If I did forget to say, if patients don't improve with conservative measures, certainly we can refer them for other treatment options. Sometimes I sent them to sports medicine to see if platelet-rich plasma injections are an option. This is when we'd order the MRI to see if we're missing anything. And patients can then be referred for surgical intervention. And with surgery, that usually entails cutting the fascia. But again, very few patients really require this, because most of the time patients will get better without the surgery. As far as custom insoles versus over-the-counter, some studies have shown that over a long period of time, there's no significant difference in using over-the-counter versus custom, though I have seen in my experience that some patients will tend to do better with custom insoles, but others do just as well without them. Moving on to bunions in the interest of time, bunions are a complex deformity of the big toe and the bone behind the big toe. And so this is what we're referring to here, this protrusion that occurs in the feet. There are many predisposing factors, some of which include being female. This is related to the just the general anatomy of the female bones, and that in some of the females having or developing bunions, they tend to have more loose ligaments or ligamentous laxity compared to the average individual. Yes, footwear can contribute some to the development of bunions, but it's not a primary reason. Patients will often say to me, I wish I hadn't worn those heels when I was younger. True, but because we know that bunions are mostly hereditary, yes, constricting footwear can contribute, especially if you're predisposed to getting a bunion, but certainly that's not the primary reason. As we get older, sometimes we're at increased risk of getting bunions because our foot mechanics change as we get older. As I mentioned before, 90% of those people with bunions had a family member who had a bunion. So bunions are strongly hereditary. And unfortunately, there's not much we can do to prevent bunions, especially if you've got a strong bunion gene. Certainly having a flat foot also alters the foot mechanics, and that increases the risk of getting a bunion as well. So as far as symptoms are concerned, people will tend to see that prominent bump that I showed you. People will have pain and shoe gear over that bump. Sometimes they can have numbness over the big toe or some burning. And sometimes people can have pain to the second and third toe joints as the foot mechanics change and people end up putting more pressure over the second and third toe joints because the big toe joint isn't functioning very well because of the bunion. What to expect? You can expect that your doctor will evaluate your foot, check on a bunch of different things to determine why it is that you're having the bunion and plan on correcting that accordingly. We'll also order x-rays to assess the severity of the bunion, to assess the quality of the joint, to see if there's an arthritic component to your joint, and to assess the alignment of your bones as well. As far as treatment for bunions, there's two paths, a non-surgical path and a surgical path. As far as the non-surgical path is concerned, I always tell people it's all about respect. You got to respect this bunion. Once you have it, you got to respect it. And if you respect the bunion, it will respect you. And how do we respect the bunion? We respect the bunion by making sure that we wear shoes that have a fabric or mesh upper. Nothing that has a firm leather upper that is very constricting to the bunion. If you wear shoes such as is illustrated here, the bunion will be happy and should not cause you symptoms. I remember when I was doing elective surgery, I did hundreds and hundreds of bunion surgeries on women and only did bunion surgery on like 5 men because I'll tell the guy, go change your shoe gear, and they'll change their shoe gear. But I'm a female. I get it. I wear shoes that I have no business wearing sometimes, but recognizing that wearing those kinds of shoes will lead to pain. So if that happens, take pain medication as needed, any anti-inflammatory if you can take it. And then it's important to get your feet measured, not just for length, but for width. Because if you're
Well, we are experiencing some technical difficulties here. Hang tight for us as we get Dr. Chianda back on. Dr. Berkowitz is joining us momentarily as well. So hang tight as
Full
we
treatment
get,
doesn't work.
oh, there she is. We lost you momentarily, Dr. Chianda, but you are back and we're going to let you take over, okay?
Oh, so sorry.
No, it was just a technical issue, so you're good to go.
Okay. Oh, so like I was saying, you can use shoe stretchers as well. These will help to keep the shoes stretched instead of your bone doing the stretching. And if you do use these bunion shields, please make sure that you have them on when you try your new pair of shoes, because space is a premium. And if you put them on and wear your existing pair of shoes, then that's going to cause pain. As far as surgery is concerned, only have surgery if the non-surgical treatment options fail to offer you relief. And I tell people, when your pain is 10 out of 10 all day, every day, and it's all you think about, and your family members are tired of hearing you talk about your bunion, then it's time to have surgery. But surgery should never be done for aesthetic reasons, because surgery can have complications. So if you end up with complications when you didn't have pain before, you're not going to be pleased with the outcome. As far as surgical treatment is concerned, there are many ways to correct a bunion. You can correct them up here by the toe. You can correct them by the head of the metatarsal here. You can correct them at the base. You can fuse the joint. Really just many ways to address how to treat this bunion. There are a few complications. Unfortunately, 8 to 78% of the time, as was written by one paper, the bunion can come back. And so it's important to make sure that the right procedure is selected so that we can decrease the chances of that bunion coming back. Again, like I mentioned before, sometimes you can end up with pain underneath the second and third toe joints due to overload. Sometimes the bunion can be overcorrected, and you can end up with that hallux varus, we call it, and delayed healing of the bone or the non-union of the bone. Sometimes people can have wound complications, nerve complications, because the nerve is right there. So these are things to keep in mind. So in the interest of time, I guess I'll stop here, because I want to make sure that we leave enough room for questions and answers. So thank you so much for your time.
Well, thank you so much, Dr. Chianda. I'm going to get us over to Dr. Berkowitz's slides. That was such a wonderful presentation. And then Dr. Chianda is going to join us in just a little bit here for our Q&A. So thank you so much for that presentation. And then I'm going to introduce our next presenter. It is an absolute pleasure to introduce to everyone Dr. Mark Berkowitz. Dr. Berkowitz is a board-certified orthopedic surgeon specializing in foot and ankle reconstructive surgery, arthritis, fractures, and sports injuries of the foot and ankle here at the Cleveland Clinic. Dr. Berkowitz completed a foot, ankle, and lower extremities trauma fellowship at Florida Orthopedic Institute following his residency in orthopedic surgery at Tripler Army Medical Center in Honolulu. He graduated from medical school from Case Western Reserve University School of Medicine and is seeing patients at Cleveland Clinic main campus as well as our Middleburg Heights Family Health Center. So thank you so very much for your time, Dr. Berkowitz. And with that, we're going to let you take it away.
All right. Thank you very much. It's my pleasure to spend an early afternoon with everyone talking about a very important topic, which is something that Stella and I and several of our partners have dedicated our lives to treating, which is pain in the foot and ankle. I think Dr. Chianda did a great job covering the gamut of common conditions that cause symptoms in the foot and ankle and are the reason that people present for evaluation. I thought it appropriate for me to be a little bit more focused and to specifically address the topic of arthritis in the foot and ankle, primarily because it is an extremely common condition that causes people issues and a very common reason for a patient to see a physician. So I'd like to spend the next few minutes talking about arthritis. I'll address it in different parts of the foot. One of the first points that I would make is that unlike the shoulder and the hip and the knee, which are one joint, the The foot and ankle is 27 different joints, and each one can be affected by arthritic change. So I'll try and touch a little bit on each region of the foot, and then pay some particular attention to the ankle, and particularly the option for ankle replacement as a way to treat ankle arthritis. So I have no conflicts to disclose. The first comment that I would make is that everybody is probably familiar with someone who's had a knee replacement or a hip replacement, but there is a lot less familiarity with foot and ankle arthritis. And I'll bet if we polled the audience, not nearly as many people would know individuals or friends who've had surgery for foot and ankle arthritis. And that's for a very legitimate reason. It's approximately 9 times less common than the knee or hip, and it less commonly requires surgical treatment. So for those 2 reasons primarily, it's less commonly experienced, and there's a lot less familiarity. This is what arthritis is. I think it's important to just understand the definition. On the top of this slide, we see pristine joint cartilage, nice and smooth. All the cells are intact. There's no damage. Contrast that with the image on the bottom. That's what an arthritic cartilage specimen looks like. It's no longer smooth. It no longer glides appropriately. And this is the reason people have pain. So this is what it looks like at a microscopic level. On an X-ray, it represents itself with narrowing of the space between the bones. So if you look at this image where the arrow is, there is less space between the bones. This is a telltale sign of an arthritic ankle joint. And then there's also some side effects of arthritis. Those generally include bone spurs. This occurs in every joint in the body, but it's more noticeable in the foot and ankle because of the thinner skin and the fact that we wear shoes. So bone spurs are a typical part of the arthritic process. There's also sometimes deformity. And you can see in this picture, the foot is turned in significantly. It's not uncommon in the foot and ankle for arthritis to be accompanied by a clinical deformity. All right. We divide the foot and ankle into essentially 4 different regions. There's ankle. Just below and in front of the ankle is the hind foot. The midfoot is in the middle of these 2 areas, and then the forefoot includes the toes and the joints just behind the toes. So these are the areas that we're going to discuss. So in the forefoot, the most common condition that is arthritic in nature is when the great toe becomes arthritic. This is actually the most common joint in the entire lower extremity to be affected by arthritis. Now, sometimes it's confused with a bunion because it can result in a significant prominence. But a bunion, as Stella explained, generally involves when the toe is angled and is crooked. In this case, the toe can oftentimes be straight, but it's stiff, it's painful, and it's arthritic. And those are the symptoms that arthritis generally presents with. The midfoot, as shown here, is in the area just behind where the metatarsal bones or the long bones of the foot are. This is essentially where the arch is. And so if the arthritis develops in the midfoot, it's not uncommon for there to be some flattening of the arch in this area as well. And that's often part of the patient's chief complaint. The hind foot is just below and in front of the ankle. This often results in limitations of moving the foot in and out or in circular motions, whereas with the ankle, it primarily affects up and down motion. So each one of these regions can be affected by arthritic change. And really regardless of where the arthritis is, we will always start with a non-operative treatment approach. The reason for this rationale is that non-operative treatment can oftentimes be extremely effective, and it precludes all the risks and the recovery that are associated with surgery. So non-operative treatment is really the foundation upon which all treatment for arthritis begins. So this can include multiple things, including weight control, low impact aerobic exercise for weight, for both fitness as well as controlling the amount of weight that affects an arthritic joint. I'm a big proponent of aquatics, using aquatic therapy and swimming and water aerobics, not only for the therapeutic nature of this exercise, but also for weight control and for alleviating inflammation within the joint. So this should probably be a part of any non-surgical treatment regimen. This is applicable even to people who don't swim, as shown in these imaging. pictures, there's lots of exercises that can be done in the pool that don't involve the ability to swim, don't involve the need for putting the head underwater, and you can still reap all of the benefits, particularly for lower extremity arthritis. Other aspects of non-surgical treatment should include anti-inflammatory medicine, and that obviously includes oral medications that can be prescribed by your doctor, but also you should be aware of the presence of very effective topical anti-inflammatory medications, such as Voltaren gel and the same medicine incorporated into a patch. So these are really effective in the foot because of how thin the skin is. And so it's very common for these treatment algorithms to be applied to anyone with foot and ankle or arthritis. Other aspects of non-operative treatment include shoe modification and the use of inserts within shoes. These can either be over-the-counter type inserts, as shown here. This is a carbon fiber insert that limits the amount of stress that gets imparted to the foot, or these can be customized inserts that your physician can order for you. The physician is generally going to be able to counsel you regarding which one is most appropriate for the condition that you have. Right. Shoe modification has to be part of the non-operative treatment regimen. That doesn't mean that you can't wear the shoes that are in your closet or that you want to wear intermittently, but I think having a shoe that is relatively stiff, very supportive, should be the mainstay of shoe wear for anyone with foot and ankle orthotics. Certainly, you're going to a wedding, you're going out to a nice dinner, it is very reasonable to wear a sophisticated shoe for a period of time. My point is simply that the good, stable walking shoes, those should be the workhorse shoe wear that someone with foot and ankle arthritis is utilizing. We talked about the types of inserts that can be used. If those are not effective, bracing can oftentimes be the next and oftentimes last step in the non-operative process. So these are generally custom devices. They are prescribed. A cast or mold is made of a person's foot and ankle, and then these types of devices are made specific to the individual anatomy of the patient. So this is considered to be the most aggressive form of non-surgical treatment, and these are oftentimes very effective in limiting the amount of stress that an arthritic joint is exposed to. These are just examples of these types of sophisticated braces. All right. If these combination of non-surgical treatments fail to provide adequate relief, that's when surgical treatment is reasonable to consider. So generally, the indications are symptoms that are severe, that are daily, and that don't respond to non-surgical treatment. Right? They kind of fall into a few different categories, including clean out or debridement is the medical term for clean out, fusion of joints, that means turning two bones into one bone, and then replacement. Not all joints are amenable to each of these three options. So I'm going to run through those four regions again, and we can address these different surgical options. Keep in mind that these surgical treatments are very different than the knee replacements and the hip replacements that people have received for arthritis in those joints. I often joke with patients that I'm jealous of the total joint surgeons because their surgeries involve people not using casts. A lot of times they're able to put weight on it right away. Our treatments are very different. They all require casting for several months. They all require not putting weight on it for several months. And this is because it takes that much time for the healing to occur in the foot and ankle. So it's important to distinguish between the recovery that might be appropriate for a knee or a hip. That's not going to be the same recovery appropriate for a foot or ankle. All right. We'll start with the forefoot. So with the great toe, if the arthritis is mild, a clean out can be considered where bone spurs are removed. This is a relatively straightforward procedure, but it's not applicable if the arthritis is more severe. So if the arthritis is severe, then a fusion of that joint is required with a longer recovery time and, importantly, loss of motion of the great toe joint. So this is a trade-off surgery. A patient trades motion to get pain relief, but it is a very reliable procedure that can help with severe pain when the arthritis is severe. Similarly, in the midfoot, there's really only one surgical option, and that's fusion. That's taking the several bones that are separate within the middle part of the foot, turning them into one bone. This can be an effective treatment by stabilizing that part of the foot and diminishing the arthritic pain, but it is technically difficult. Usually it's multiple joints, not one, and so the recovery is oftentimes prolonged. This is an example of someone with an injury to the foot resulting in flattening of the arch, and then this is ultimately treated with a midfoot fusion. Okay. Same type of approach with the hind foot. Really the only surgical option when these joints become badly arthritic is a fusion. So there are 3 joints here. Depending upon which joints are involved, either 1, 2, or all 3 of these hind foot joints can be fused as a way to diminish arthritic pain in the hind foot region. In the ankle, we have a few more options. If the arthritis is mild, an arthroscopic cleanout can be utilized. This is a picture from an arthroscopic procedure. So using small incisions to place a camera within the joint allows for a cleanout of any damaged cartilage without a lot of large incisions. Now, this is obviously attractive because it's minimally invasive. The key element here is that it does not eliminate the arthritis. It's simply a cleanout. The patient still has an arthritic joint, and so the amount of pain relief that can be provided by this procedure can often be somewhat unpredictable. The 2 definitive treatment options for the ankle are fusion and replacement. So fusion 40 years ago was considered the gold standard, and in some cases it still is today, particularly in patients with deformity, patients who are obese, who have significant comorbidities. A fusion is still a very reliable and very effective treatment, but it does sacrifice the up and down motion of the ankle. And so in order to preserve that, a lot of attention has been paid to ankle replacement. Now, ankle replacement has not been around nearly as long as hip or knee replacements, and it's gone through some significant growing pains. So back in the 80s and 90s, when this treatment was just being developed, the results were really unpredictable. And when these would fail, the results were sometimes catastrophic. There's been a lot of advances that have been made, particularly over the last 10 to 15 years. Some of these are shown here. This is what can happen when an ankle replacement goes bad, where the components dislocate. But in the current technological environment, this is what can be expected, where an ankle has the damaged bone and cartilage replaced with metal and plastic. And the major benefit of this is that it allows for preservation of motion. So here's a 65-year-old female who underwent an ankle replacement for arthritis that developed after a fracture. This is the type of motion that she's able to demonstrate. This is simply not possible when an ankle fusion is chosen as the surgical procedure. So orthopedic surgeons remain very optimistic about the evolution of ankle replacement. There is obviously potential for continued benefit and improvement in terms of the technology and how this technology is applied to patients. But these now are the spectrum of treatment options that we have available for foot and ankle arthritis. They continue to improve, but I think it's important to understand the differences between treating hip and knee and shoulder and foot and ankle, but the results can be rewarding when applied to the right situation. So that's the end of my talk. I am, again, very appreciative of the opportunity to engage with everybody in the audience about this topic.
Thank you so much, Dr. Berkowitz. That is just absolutely incredible. The photo that you showed at the end, that is just incredible to see how far that has come along since what you were saying, the 80s and 90s. So thank you so very much for that presentation. We are going to welcome Dr. Chianda back up on the screen here and go through some of our Q&A. So upon registration, many of our attendees had submitted very thoughtful questions, and we have certainly sent those questions to our presenters. So I know that many of those questions were incorporated in those presentations, some of which we are going to touch upon again, just for additional information. But of course, throughout your presentations, we were receiving questions as well. So we want to ask those of both of you during this time. I think we're going to have plenty of time to get through some of our more dire questions too, which is great. The first question that I want to really pose to both of you is, I know that through conversations with our audience and with both of you, one of the first questions that we're always asked for this event is, where would someone start when someone is looking for care of their foot? They have a foot pain or an ankle pain. Where is it that they start with somebody here at the Cleveland Clinic?
You want to get that one, Mark?
Yeah, well, I think the answer that I would provide to that question is that we have multiple ways for patients to enter our system and begin to get answers to their questions. I do not think that there is one particular pathway that's going to be right for everyone. We try and provide and establish foot and ankle specialists throughout Northeast Ohio. So we have a regional approach where we place people in different aspects of the community, different locations, so that patients can conveniently reach out to and engage with our caregivers. So oftentimes that's the place to start, is the location and the provider that's easiest. Once you get into the system, then we're better able to guide the patient. Once they've had an initial evaluation, whether that's with an orthopedic surgeon, with a podiatrist, with an advanced nurse practitioner, or a physician assistant, then we can identify what the problem is, begin to treat with some of the basic non-surgical modalities, and then based on the response to that treatment, that will then guide where they go next. If a patient responds extremely well to basic non-surgical treatment, they might be all that they need. I'll give you an example. I see a good number of toe fractures. Oftentimes, patients just need some basic treatment, some reassurance that this is going to heal, and they do not need to go on within our system. Arthritis might be a different situation, where they begin with one of our caregivers in their local community. They receive some anti-inflammatory medicine, an injection, some bracing. And if these things are not working, then they will be referred on to a surgical specialist who has particular experience with that particular condition. And then the treatment can pick up from there. So I think, I don't mean to be too wordy, but I think the answer is just getting into our system is probably the key step. It doesn't really matter where. Once you're involved, we can begin the treatment plan, and then we can guide the individual patient depending upon their unique pathology and how they respond to the treatment.
That's wonderful. Thank you very much. And I'm sure that that's going to be applicable to many of our audience members. So thank you for that. I wanted to ask a specific question of you, Dr. Berkowitz, in regards to if somebody is at the point where they are going to be needing surgery, you have met with them, they need surgery. I know both of you touched upon weight. Is there an appropriate BMI for somebody that is going to be needing a surgery? Is there something that you look for, or what would be that measurement? Yeah,
I do not think that there is a number. I think the term that would be used is the weight optimized? Okay. So optimization is going to have a different numerical value for every given patient. If a patient has, I'll just give an example. I mean, if they are they start their process and they're 400 pounds and have diabetes, but they go through an extensive treatment regimen and they present to me at 280 and their diabetes numbers look significantly improved, that might be the best that they can do. That's a huge improvement from where they started, and they are probably optimized. That's the best that is going to be expected. Again, in contrast, a patient who comes in who smokes, doesn't work out, weighs the same 280 pounds, or has the same BMI, they're not optimized. So at the same value, they're just not ready for surgery, and they would likely be encouraged, if not instructed, to, hey, you got to get into a aerobic fitness regimen. You have to stop smoking. You have to drop some weight in order to become a better surgical candidate. So, optimization, I think, before surgery is mandatory, but it's probably not going to fall under a specific number. It's going to be unique to each patient.
That's perfect. Thank you so much. Dr. Chanda, one of the questions that we received, I'm just going to read it. It says, my bunion is relatively new. It's not causing pain just yet, but at what point should I start to seek help for that bunion?
Honestly, I would say if it becomes symptomatic, at least I would hope that after hearing this lecture, you get a sense of it's not anything to be concerned about unless it becomes symptomatic. And to that end, recognizing that you now understand why you have a bunion. If it's not symptomatic, there's no need to seek treatment, because there are many people walking around who have bunions who go about life.
Perfect. Thank you. The other question that I wanted to pose to you is, you both touched upon footwear, and what I've been able to glean from listening to you is that it is very important. The footwear that we wear is important. So I wanted to touch base and just elaborate a little bit more on that. And I know you covered it and it was fantastic, but what would you recommend as the best walking footwear or arch support if somebody has arthritis in their feet?
Yeah, I'll take a stab at that. I mean, I think that it's important to not be dogmatic about shoes, because everybody's taste and preference and comfort level are different. I tend, rather than recommending a specific shoe, I will do two things. Number one, I will tend to recommend shoe stores. There's the mall, the store at the mall that might not be right for everybody, particularly if they have some issues with their feet. But there are really good shoe stores, such as in this area, Lucky Shoes, Foot Solutions, the Good Feet store, Healthy Feet. Like, these are places that specialize in good shoes for people who need them. And their employees tend to be very sharp. And so a patient who presents to one of these stores and says, hey, my doc told me I have foot arthritis and I need some good shoes, they'll go into the back, bring out 8 different styles, 8 different brands, and then the patient gets to choose the one that feels best for them. So I think that rather than saying, hey, this shoe is the one everybody should wear, it's better that they look for and try on a number of different styles. I do think, though, that if there's a common thread, the shoe should be have some stoutness to it. I call it the pretzel test. If you can take a shoe and bend it and twist it and move it around easily, that means your joints are going to be seeing that amount of bending and twisting and stress when you walk. So you would generally do better with a shoe that doesn't bend as much, just has some stoutness to it. And so if they go to a good store and they find a shoe that has that characteristic, usually that's going to be an improvement.
Excellent. One of the follow-up questions that I have is footwear inside the home. So we kind of hear, some families are very much like, no, you can't wear shoes inside the house. And, you take off your shoes and you're walking around barefoot or in socks. Do either of you have a recommendation? Is it actually better for our feet to be wearing a shoe, a clean shoe, maybe inside the house that you have? Or is it better to be barefoot, or does it depend on the person?
I guess I can answer that one. Again, we keep mentioning that there's variability in the recommendations that we give people, because it is true. Depending on your foot condition, it's not recommended that you walk barefoot at home. For example, if you have plantar fasciitis, like I talked about, certainly detrimental to your goal to getting better. If you have a neuroma, or if you have an inflamed joint on the bottom of the foot, it's not a good idea to walk barefoot. People with high arches will certainly benefit from avoiding barefoot walking because of the decreased shock absorption that their feet have. But then there are other people who don't have any foot problems, don't have any issues, and they would be okay with walking barefoot at home. And so I think depending on your diagnosis, depending on your foot structure, and depending on whether you have diabetes or not, because obviously if you have diabetes and don't have any feeling in your feet, it certainly isn't wise to walk around with just socks or barefoot, because that increases the risk of injury to the foot because of the lack of feeling. So I guess the long and short of it is it's pretty variable. And depending on the situation, we will advise whether to or not. And there will be certain brands of sandal or that we would recommend, at least that I recommend, depending on the diagnosis.
Wonderful. Thank you. Dr. Berkowitz, I wanted to ask, we had received a specific question, so I want to pose this question to you. How long, in your recommendation, is the typical recovery from a mid-foot surgery?
From what type of surgery?
Mid-foot.
Yeah, so like a midfoot fusion, as I showed for, as is commonly done for arthritis, one of the challenges is the prolonged recovery. The reason for the prolonged nature is because two things have to occur. The first is fusion. The bones have to knit together. These bones have been separate for a patient's entire life. And with a fusion, you're trying to then turn them into one bone using metal and bone graft. So for that process to occur, it's a 3-month biologic process for those bones to become one. So generally, people are in a series of casts for most of that 3 months, generally in the 10 to 12 week range. And then once the casting is finished, the initial weight bearing is done in a removable boot. So I would hazard to say that the first 4.5 months are generally in some form of a device, a cast first, and then a boot, which is why when I quote people a recovery of somewhere around 6 to 9 months, that includes the time to heal and then the time to get used to that healing and to rehabilitate. So these are not super fast procedures. And as I contrasted in my talk, I mean, I have a lot of envy for the total joint surgeons and their ability to do hip replacements and patients walk out of there. Unfortunately, that's just not applicable to this type of surgery.
And that's fair. They're very different. So I appreciate that. One of the questions that I want to pose really to both of you is for our older population, is there anything that you would, both of you would recommend to perhaps increase stability in their ankles if they find themselves feeling like a little unstable?
Yeah, the first suggestion that I would make is, elements of yoga closely mimic what we consider physical therapy in a lot of ways. Like there's a ton of overlap between those two things. And so basic yoga type of activities, and I don't mean, standing on your head or doing anything that is complicated, but holding very basic poses, standing on one leg, drinking your coffee while you stand on one leg. Like those are extremely beneficial for improving one's balance, for strengthening the small muscles in the foot and around the ankle. These are not big muscles like you work when you go to the gym or lift a barbell. These are the small muscles that keep you from falling, that allow you to be on uneven ground. So I try and kind of feel out if a patient is more comfortable with a referral to physical therapy. That's an easy intervention to initiate. If they would rather do this on their own, then I generally steer them toward some basic yoga practices that again, do not have to be complicated. You do not have to be a yoga expert to engage in some of these very basic balancing type of activities that can be done on a daily basis as part of your morning routine.
Wonderful. And then Dr. Chanda, is there anything additional that you'd like to add as well?
I guess, in addition to that, I would just like to, I find a lot of my senior patients sometimes tend to be a little resistant to using gait assistive devices. And I think it's important if the strengthening part isn't working very well, we want to obviously avoid the risk of falling. And so we can refer patients to physical therapy for gait assistive device evaluation. And essentially the physical therapist assesses the patient's gait and then determines whether a cane would be better, a rollator, or a walker. And I think at some point, for safety reasons, it's important for patients to be open to the idea of getting a gait assistive device. And that would be something that we would do as well with physical therapy.
Wonderful. Thank you very much. One of the questions that I want to pose to you, Dr. Chanda, that we received is regarding Epsom salt. And is that ever something that you would recommend with somebody that is struggling with a foot or ankle pain to do like a soak in that?
I'm not generally one to recommend warm water soaks. I do recommend Epsom salt soaks, though, for patients who perhaps a patient who came in with an ingrowing toenail, and this just helps with bathing the wound and offering cleansing of the wound. So we do recommend soaks then. Depending on the nature of the situation with the toe injury, for example, if a patient steps on glass and we're not able to retrieve it, I might recommend a different type of soak that's an astringent, and that's really good at drawing out toothpicks and drawing out pieces of glass. But in general, just to do it as a way to relax, I guess if you want to, that's fine, but it's not something I would recommend as a beneficial treatment to the things that we typically see in the clinic, aside from the things that I just talked about.
Wonderful. Thank you. And while you were presenting, it was very interesting, the fact that for like plantar fasciitis to not use heat, I wouldn't know that. So that was something that I learned during your presentation. That was fantastic. So thank you for that. One of the questions for you, Dr. Berkowitz, that we had is that in the second toe, is it possible to do a joint replacement specifically in your second toe?
So unfortunately, I mean, joint replacement in any of the toes has yet to reach the level of success of a knee, hip, shoulder, elbow. The problem, those technologies do exist for the second toe, for the great toe. The problem is that the bones are so much smaller that any joint replacement is, in order to succeed, there has to be successful bonding of the metal to the patient's bone. That's relatively easy to achieve in the hip and the knee because there's so much bone. The bones are so large. But when you get to the smaller bones of the hands and feet, it's harder. So in the hand, particularly for patients with rheumatoid arthritis and other conditions, there are joint replacements, but you don't walk on your hands. So they're not subjected to the amount of stress that the toes and the feet are. So the answer to that question is yes, these technologies exist, but the predictability and the success rate of those types of procedures is still not at the level where we would like it to be. And so that's not a surgery that I think you would recommend without reservations for a patient.
Thank you. And then following up, you had just briefly touched on RA. In your opinion, are there any foot issues that somebody with a diagnosis of RA may that you might often see?
Sure. Yeah. No. Historically, and by historically I mean 20, even as recently as say 20 to 25 to 30 years ago, the rheumatoid foot was like a huge component of most surgeons' practices. It was something that was extremely common, could often be debilitating in the form of arthritis, and oftentimes produced significant deformities, making shoe wear difficult. So just within the last few decades, that was a major part of orthopedic surgeons' practices. What changed are the improvements in the medications. So the biologic medications that are now commonplace for patients, they have really been so successful that both the severity and the frequency of bad rheumatoid arthritic changes in the foot have significantly decreased. I think at this point, I do one rheumatoid foot reconstruction probably every 1 or 2 years as opposed to it being a very, very common part of the practice. So the answer is absolutely. It still does cause some issues with arthritis in the joints of the foot, but not nearly as commonly as in the past and not nearly as severely. And that's owing to the advances in the medical treatment.
Wonderful. Thank you. And kind of going off of that a little bit on, as we're talking about arthritis, is there any correlation between bunions and a foot arthritis? Is that something that they're correlated, or is it just completely separate?
I think that in general, I would say that they're separate, but the one exception to that is this. I mean, if a patient has a bunion, particularly for a long time, that bunion can develop arthritis over time. And so and Stella, I'm sure can weigh in on this. You can absolutely have a patient with a bunion and no arthritis, and that's treated in one way. And then you can also have patients, not uncommonly, with a bunion and arthritis in that same great toe. And those are generally treated with some other things. But yes, it is possible for them to coexist, but they can also occur separately.
Wonderful. Dr. Chianda, was there anything else that you were going to say?
No, I think Dr. Berkowitz summarized it very well.
Excellent. Perfect. I love it. You guys are on the same page. We're working as a team. I love it. I wanted to touch base on, I know we briefly touched upon the injections, but is there anything that we can elaborate a little bit more on, like PRP, stem cell, any of these treatments, when they would be applicable, when they would not be, anything else, I guess, to add or expand upon in regards to injections?
Yeah, well, I mean, it's a large topic and obviously complicated, but I think there's a few points that people should be aware of. I think in summary, PRP injections are not at a level of advanced scientific understanding where we can clearly say, this is what it's good for, and this is what it's not, and this is how it should be utilized. And one piece of evidence of that is insurance does not pay for PRP injections. When you talk about Medicare, Medicare tends to pay for things that are clearly proven to be effective and proven through rigorous scientific studies. So, for instance, many patients may be aware of people receiving gel injections in their arthritic knee. Well, those gel injections are reimbursed by Medicare because they've been studied so extensively and have been shown to be effective. PRP does not have that scientific background supporting its use. That doesn't mean that it can't be helpful, but it is not at the level yet where an insurance carrier will say, yes, we will foot the bill for that treatment. And so my understanding is that those treatments can be over $1,000, that they're often a series of injections. And I can't help but listen to the radio and hear ads for facilities that are making a nice profit off of patients paying out of pocket for PRP injections. So PRP injections hold some promise. And I think hopefully with enough study and enough development in the future, they can become a mainstay of treatment. But I think patients need to be aware that they're not quite at that level of scientific support where they can be a mainstay or a foundational treatment.
Wonderful. Thank you. Dr. Chianda, I want to ask you an additional question that we received, and it's really just kind of about the arch and the shape of the foot. And if these kind of unique, like if somebody is a totally flat foot versus a high arch, the shape of the arch, does this affect the foot in general, just like on its own? Is that something that somebody would need to see somebody if they have a high arch or a flat foot, or when would they see somebody if that's what's going on with them?
I think that's a very broad topic, and it's hard to really kind of address it directly, but I'll try my best.
Sure.
So I often say your foot type is really an issue when it becomes symptomatic. And I think for most of us, I see many people with wickedly flat feet who are asymptomatic, never have any issues. And then you see some people with a mild flat foot that's symptomatic. So depending on how your body has compensated or adapted to your flat foot, you might be okay and go through life and never have any issues. And so patients often ask me, well, should I wear an arch support if I'm flat-footed? I'm often a little reticent to tell them to wear an arch support, because wearing an arch support does change the position of your knees, it just change the position of your lower back, etc. And so if you're asymptomatic, it might cause problems in your lower back. So I tend to say if you have a flat foot that's asymptomatic, you're fortunate enough to where your body has been able to compensate for it and go about. That being said, if it is symptomatic, certainly it's important to wear arch supports and to support the bones so that we can reduce the stress on the tendons and the joints that tend to suffer from having a flat foot. With regards to the high arch, though, my approach is just a little bit different, only because we have seen that high arches, as I mentioned before, don't have a lot of shock absorption. And so what I find is people can be asymptomatic throughout their 20s, 30s, 40s, 50s even. And then when they're in their 60s, they come in because they're just having generalized issues. And this is just from long-standing bone stress because of the lack of shock absorption. So in my patients with high arches, over the years, I've kind of pivoted a little bit that even if it's asymptomatic, as a way to prevent those future issues that I've seen arise, I always encourage them to just always make sure that they do wear arch supports with maximum cushion. That way we can protect their bones in the long run. And also with shoes that offer a lot of cushion, again, for the very same reason. So my approach is a little bit different for the 2 feet, only because of the long-term ramifications of the two. But I guess that's a quick summary of that.
That's wonderful. Thank you so much. And with that, I want to thank both of you for your time today. Both of your presentations and your time with us during these questions has been fantastic. I cannot thank you both enough for your time today. I want to let everyone know a little bit about what to anticipate, what's coming up next. So in the coming day, you're going to be receiving a recording of this event. You will receive all of the handouts that are, again, at the right hand of your screen. All of those resources, both from the Cleveland Clinic as well as the Arthritis Foundation, are going to be found there. You can share this with anybody that you might think would be interested or would benefit from it, or of course go back and watch some of the parts that maybe you missed today live. So that's going to be coming up next, and that will be in probably tomorrow. You'll receive an email for that tomorrow. And then again, these are some of our additional resources that can be found in the handout section. We want to thank everybody for tuning in. Thank you again, Dr. Chanda and Dr. Berkowitz, for your time today. And with that, I hope everybody has a wonderful rest of the day. Thank you all so much.
Thank you for having me.
Thank you.